Good afternoon, everyone. This is Dr. Mark Rudolph, Sound's Chief Experience Officer. Thanks very much for joining us for this week's COVID-19 clinical webinar. As always, we will have Q&A at the end of the presentation, so please feel free to start submitting questions whenever you have them via the webinar control panel. We are recording the webinar and we'll send all of the invitees a link to the recording as well as any resources that are mentioned afterwards. At this time, I'd like to turn it over to our CMO presenters, Dr. Nate Ruck, CMO of Emergency Medicine, Dr. Gregory Johnson, CMO of Sound Hospital Medicine, and Dr. Sergio Zanotti, CMO of Sound Critical Care.
Thanks, Mark. Appreciate that. We will begin the webinar, as we always do, by continuing to thank everyone for their fantastic work. We'll be highlighting some of the increase in volumes and know that obviously this is materially affecting all of our clinical teams, but you continue to do outstanding work that we not only see in the data, but hear about on a daily basis through communications that are coming through the leadership team. So thank you for continuing to do such an exemplary job in caring for the patients and the communities that we all serve. As you know, we have our typical agenda. First, the Sound update that I mentioned before, where we'll give an update with respect to COVID volumes, an update on vaccine status, information on the infodemic and sensible medicine, as well as an update on remdesivir. As always, our follow-up on clinician well-being, and then, as Mark mentioned, our question and answer session at the end. Please don't hesitate to put in your questions as you have them within each section, and Mark and Stephen will help to identify which ones will be presented and asked to the panelists. So moving forward into the Sound update, I believe everybody's familiar with this. I know Rob shared on the virtual village a few days ago that the total number of active COVID cases in our critical care and hospital medicine programs has continued to rise. We're, as of this morning, at 3,802 active cases, not necessarily confirmed. And as you can see, we're also seeing an uptick in terms of new patients. We actually hit an organizational high of newly admitted and suspected COVID patients. We're in the midst of another spike, and we're obviously addressing that. The following slide really gets into where we're seeing this. If you move forward, we continue to have a significant concentration in the Midwest, and then for our critical care programs that are highlighted in gold, while they tend to be a little bit smaller with respect to the total size of the program, as you can see, Jackson-Madison County, which is in Tennessee, has had a significant uptick of over 110% increase just in the last week. All of this is meaningful in terms of how we are staffing our programs, and we're keeping an eye on that. We have had an uptick, unfortunately, in terms of the number of clinicians that have been affected. Fortunately, again, minimal numbers in the hospital, but anybody that's affected, we're obviously concerned and continuing to pay significant attention to those spots. This will reinforce, obviously, our offerings of PPE. We still have masks available, both surgical and KN95s, and encourage people, should they wish to receive them, please don't hesitate to reach out to us centrally via the COVID website. Lastly, in our update, we have our ongoing visibility with respect to the suspected and confirmed cases, as well as the overall mortality. We again can have continued to see that the mortality on the far right, really our Medicare population, those 65 and older, the mortality has remained relatively steady, but continues to be the highest. And again, that's consistent with the national data that we've seen. As far as confirmed cases, we have had a mild decrease in terms of patients that are under the age of 55, although if you look at the aggregated groups of between 40 and 64, that has been an ever increasing number of confirmed cases within our hospitals. Again, we thank you all for continuing, particularly our hospital medicine and critical care teams, for continuing to collect this data. I think many people are aware of the New York Times article that was based on a lot of the data that you guys are sending in with sound in partnership with Dartmouth College. With that, we'll move into the vaccine update. And part of the reason we're doing the vaccine update is that it's been significantly in the news of late. I think these are pulled from both websites, news websites, as well as newspapers regarding early data around the Pfizer vaccine, noting that it's 90% effective. This being a clinical webinar, we want to get specifically into the details around this, so that way you are better educated and continue to educate not only your colleagues, but our patients with respect to this. So jumping into the next slide, just a little bit of background with respect to the Pfizer vaccine. First of all, it's being done in partnership with a German company, BioNTech, and obviously Fosun Pharma that is listed. For background, Pfizer originally started with two separate vaccines. Both of them are mRNA vaccines, and again, they've been focused on eliciting a neutralizing antibody response, so focused on a humoral response against the spike protein, which is highlighted by the red arrow. That infographic is one that we've utilized a number of times on prior webinars, just to remind everybody about the morphology of the SARS-CoV-2 variant. And the spike protein has been the key area of focus for most vaccines. And again, this is specifically around the spike protein. Of the two vaccines that were trialed, one of them, and you can see the name there, it's a technical one, appears to stimulate both a cellular and humoral response, and it had a slightly more beneficial safety profile. More specifically, fewer patients had fever and myalgias with respect to comparing the two vaccines that were trialed. And so only one of the two was advanced to phase 3 trials, and that's the one that's being reported on currently. If we advance forward, this is the timeline just for perspective on how quickly this vaccine has been developed. Again, back in May, this was when the phase 1 and 2 trials, and for those who aren't familiar, they've been combining a number of phase 1 and phase 2 trials for a variety of vaccines in an effort to make sure that things can be accelerated. A lot of that is based on the fact that much of the technology, specifically the vectors to deliver the vaccine, have been tested previously in the case of SARS and MERS. But with respect to what we've identified with this, it was phase 1 and phase 2 trials to identify those two vaccines. In July, so relatively quick turnaround, the safety profile was felt to be comfortable. Phase 2 and 3 trials were launched with approximately 30,000 volunteers in a number of countries, including Brazil. And then the trials were expanded to over 40,000. And this one unique aspect of this vaccine is that this one is including children. And I believe it's the first US vaccine or first vaccine trial that is including children in the United States. Now, as far as other things, first off, we want to share what we know. It has been identified that for the patients that this was tested on, and it was 94 patients in this, the beginning portion of this phase 3 trial, it was 90% effective. For those who have been keeping track, the FDA and a number of other agents really were looking for a vaccine that was about 55% effective. And so that is the 90% is really why people are getting so excited about this. The vaccine does require 2 separate doses over the course of a couple of weeks. But one of the biggest issues that is also going on with this is the storage requirement is negative 80 degrees centigrade, or negative 113 or so degrees Fahrenheit. So storage is going to be, storage and transport is going to be a significant aspect if this vaccine continues to be as favorable as we examine it. What we don't know, and this has been stated by a number of experts, including Dr. Fauci, is we don't really have any more data other than we know it's on 94 patients and they reported 90% effective. I think a lot of people are excited, and I don't want to be Debbie Downer, but I do want to make sure that we tap the brakes because I think, as with everything that we've gone through with COVID, we really want to check the details with respect to the actual data and performance. We also don't know how long this vaccine is effective. If we are looking at the existing studies out there, lots of commentary on the fact that the humoral and cellular response may only be between 8 and 12 weeks, which could mean that outside of the 2 initial doses that there would have to be repeat dosing on a regular basis. So that's information that we don't know yet. And while none of the existing phase 3 trials have demonstrated any disease enhancement, the simple fact of the matter is that that has been identified as a particular area of concern, particularly when this has been when other vaccines for coronaviruses have been trialed in the past, again, with our experience with SARS-CoV-1 and MERS. So lots of excitement, but lots of additional information that we need to be able to work through before we really are looking at this particular vaccine as a candidate. Also of note, and I didn't document this on the slide, the Moderna and NIH vaccine is also another mRNA vaccine with very similar qualities and will also be releasing its data in the near future. If we jump to the next slide, I think I mentioned the Moderna piece, and it's just an update on the other vaccines. I think Moderna, in light of this, the Pfizer information, is really interested in publishing its data particularly soon. I think what's exciting about the Moderna and NIH vaccine, is that it would give us potential options. It too requires 2 sets of dosing, but it also generates both a humoral and cellular response. And I think that that's a big difference in terms of identifying the longevity of any vaccine. What's on the left with respect to the AstraZeneca and the University of Oxford vaccine, or what is commonly known as the ChAdOx vaccine, again, humoral response noted, but there were 2 patients, and it was 2 individual patients that developed one syndrome that was really associated with multiple sclerosis and another with transverse myelitis during the phase 3 trials, and this is why this particular vaccine was paused. It was resumed a few weeks ago because these were felt to be individual cases, and that is some of the update with respect to that vaccine. Jumping forward, other vaccines that have hit the news are the Sinovac vaccine. This, again, was the chemically inactivated whole virus that is from a Chinese company. And this one also developed neutralizing antibodies. However, in the news today, Brazil had suspended the phase 3 study. There's not a lot of detail about why this was suspended, other than the commentary that a patient or more than one patient developed serious symptoms. There's a lot more detail to come with respect to this, or at least ideally we will get that. But of note, at least this particular trial has been held up in Brazil, China, and Indonesia, which are also participating in phase 3 trials for the Sinovac, have proceeded with the phase 3 trials. Now, for as much as excitement as we have around the vaccine itself, one of the issues that we're going to have to deal with are, again, individuals' willingness to take the vaccine. This is, again, an article that you guys can identify that came from the Annals of Internal Medicine a few weeks ago, and a survey that has identified, and I think this has been supported by other surveys done by independent organizations, indicates what you see in gold there. 3 in 10 adults weren't sure they would accept the vaccination, and at least 10% didn't intend to be vaccinated at all. Reading into this, there are a number of specific populations, including patients of color, specifically Black patients, those who are elderly that specifically identified as populations that would opt out. And I think that as we get excited about the potential for vaccine and we consider the populations that are going to have to be prioritized with respect to receiving the vaccine in order to minimize the number of hospitalizations and potential deaths that are associated with this, we can't forget that there's still going to have to be significant education that goes to our patient population and, quite honestly, to other healthcare workers in terms of overcoming this particular barrier. And so I think it's an obligation for all of us to figure out what are the best methods that we can do to alleviate some of the anxiety and concern around a potential vaccine, and making sure that people are going to take it so that way we maximize the overall effectiveness within our communities. With that, I will transition over to Sergio.
Thank you, Greg. And once again, reiterate what Greg mentioned at the beginning, our ongoing gratitude for all the effort our teams are putting at the bedside and really making a difference. We know that some of our programs, once again, are seeing increasing numbers in their COVID patients, and there's also increase in volumes from non-COVID patients. So thank you for all your efforts. I will continue and talk a little bit about the infodemic and how we can practice sensible medicine moving forward. Despite being still in the midst of the pandemic, I think we now have some time to reflect and look at what has happened. And as all of you know, we have discussed this before, the idea of not only dealing with a pandemic, but an explosion of information that has been termed an infodemic, especially amplified through social media, with a significant amount of misinformation, has really caused not only a lot of distrust in the public, but also led, as we'll see, to difficulties at the bedside for clinicians. Next slide. This infodemic really has caused, I think, tremendous problems with our ability to practice evidence-based medicine. But let's just look at some of the interesting characteristics of this infodemic. This is one study out of Cornell that looked at 38 million pieces of content published in English language and traditional media through a period of time from January to May 26 related to COVID. And what they found is that 2.9% of all these publications were labeled as misinformation or either fake or misleading. So it's not an enormous percent, but yet it seems that it propagates much more quicker or with a lot of amplitude through the society and creates a lot of problems. Next slide. Of these 2.9%, which is a little bit of over a couple million publications, these are the themes that were involved with misinformation. As you can see, the most significant theme and most frequent by far is the idea of miracle cures. And not only miracle cures, but I think also there's been a tremendous amount of overemphasis on very early findings. And we can probably count how many times have we read in a headline in the news about a game changer in COVID. Yet we're several months, almost a year into this, and the reality is that that game changer has not crystallized yet. So there's also a lot of misleading information out there relating to therapies. And I think that's what's caused the most trouble for clinicians. You can see that other themes that are highly popular are a new world order or deep state, where people believe that very prominent, either wealthy or elites are doing this on purpose, Democratic Party hoax, that this is a bioweapon. Bill Gates seems to be very popular. A lot of people believe that either he created the virus or he just proposed it forward so that he could create a vaccine. But then 5G and a lot of other themes, as you can see. But by far, the miracle cure is the predominant one. Next slide. This is another very interesting study that actually looked at specifically only at misinformation and how these are propagated, especially through social media. And what they found is that when they look at the whole sample of both traditional media content and what is created in social media, it seems that the majority of misinformation is propagated by what they call bottom up, which is individual users sharing what they read or something that somebody else forwarded to them. However, when you only look at the share of all social media engagements within social media content, what's very interesting is that the vast majority of these are generated from what's called top-down. And the top-down refers to either celebrities or political figures that have a tremendous number of followers, and they will propagate misleading information that then will be retweeted or reposted or reshared over and over again, and really creates an enormous chain of amplification that helps disseminate this information. And obviously, for prominent figures that are either political, celebrities, or other types, followers are likely to believe what they're propagating. So this becomes a very dangerous way of propagating misinformation and amplifying fake news or misleading stories. Next slide. There's also been a tremendous growth and infodemic within published scientific literature. And what you see here on the left is from January to June, three lines or three groups that show you the total COVID-19 publications, what's been peer reviewed, and preprints. Preprints are usually made available before peer review, and these preprints or pre-reviews is something are a phenomenon that were not very common in the past, but now obviously people will see something in preprint and just disseminate it without even reading it, and that I think becomes a problem. On the right, what you see is the PubMed searches, and this is recently I looked at this, and we had 67,000 peer-reviewed publications in PubMed under COVID-19. So for 1 year, clearly an amazing amount of literature in the medical world. Now, not all these have the same quality, the same scientific rigor, but these are all PubMed certified or PubMed registered publications, which I think really just illustrates that the infodemic goes to the social, at society level for the public, with lay information and misinformation, but it also impacts the scientific and medical community, maybe not with fake articles that are somewhere retracted, but really with a lot of different grades of scientific rigor and strength. Next, please. And this has created a lot of problems for our clinicians. These are all therapies that I believe patients within Sound Physicians have received. Based on my discussions with our clinicians at one point during the pandemic, any one of these was prescribed to patients under our care. And clearly it creates a tremendous challenge with growing numbers, a lot of unknowns, and a lot of pressure from the public for what to do and what not to do. So the second portion of this presentation really relates to how can we move forward and practice what's called sensible medicine. But before I go there, just kind of explain why this happens. Why do good clinicians end up prescribing medications that have no proof? Why do they end up doing things clinically that in retrospect now and with time to reflect don't seem as great ideas? And it has to do with heuristics and cognitive biases. So we are programmed to take some shortcuts that allow us to navigate the complex world with multiple inputs coming at us at all times. But these heuristics can also sometimes lead to some cognitive biases that, when we don't recognize, can have us make decisions that maybe are not in the best interest of our patients. And some of these heuristics include availability, which is we will recall, or we have available what is vividly and easy to recall. So the story, a dramatic story of the doctors in Italy utilizing X, Y, and Z therapy with great success in March, is something that in April, a lot of our clinicians would have available to them and very quickly utilize that to maybe justify what they were doing. Same thing with anchoring. Once we get an initial set of information, it's very hard for us to process additional information and add that. And that is when somebody sells you a patient as a COVID patient and they're having cardiac issues, you're more likely to attribute that to COVID cardiomyopathy, which you heard about recently, as opposed to recognizing that they also have EKG changes, that they're a 55-year-old male with risk factors and might have coronary ischemia. So this is something that also has occurred a lot in treating COVID patients. Confirmation bias is prevalent not only within science, but also in all realms of society. And that basically just speaks to the fact that we are much more likely to give credence and weight to stories or studies that confirm what we already believe. So you can see that people who felt that hydrochloroquine was a great idea would take any study, no matter how poor the scientific design was, that was positive, and use that to support their confirmation bias that we should be using hydrochloroquine. Same thing with belief in small numbers. We see maybe what Greg shared is an example. 94 patients is not a big number. 94 patients, 90%, okay, that sounds great, but I would be much happier if it was 90% of thousands of patients. So we tend to give a lot of value in small number sets, and we tend to not remember that the smaller the number that we're looking at, the more likely that random effects could be in place. And finally, one of my favorites is the Dunning-Kruger effect, which speaks to people who don't know a topic deeply or are not true experts, are much more firm in their belief that they're right. And this is something that I see over and over again in medicine, where people who do not have maybe the depth of expertise or have not taken the time to really study certain diseases or certain areas feel very confident of the fact that they should be using, for example, an IL-6 inhibitor in this case. And that these heuristics, these cognitive biases, I think have been why so many clinicians have utilized a whole set of therapies that truly did not have the scientific backing for our patients. Next. A lot of people say, well, what do we have to lose? Why not use a drug that maybe is safe in patients? Well, there's a lot to lose, and there's potential for harm in these patients. A drug such as hydrochloroquine or ivermectin, that might be very safe in patients who are not critically ill or are not in the hospital, it might have unknown consequences in patients who are extremely sick. So there's tremendous potential for there to be more harm than benefit, and we have to be very careful. Another potential harm is that we might impede the advancement of robust science. Now in November, we are seeing a large number of studies being finally published. Yesterday, a large study, randomized study with hydroxychloroquine in hospitalized patients with COVID-19 was published, and once again, a negative study. Those are the type of studies that we should have been doing from the get-go in order to get the answers a lot quicker. Part of the problem with doing those studies is that as people start using therapies and believe that they are useful without any proof, we have a tremendous impact on clinical equipoise. So some clinicians in March and April would not enroll their patients in a randomized study with, let's say, hydroxychloroquine because they felt that the patients should be receiving it because that's what everybody else was doing. So clinical equipoise is also harmed, which again has an impact in terms of our ability to get the right answers. And finally, I think when we dedicate our efforts to unproven therapies that could be harmful, we create distractions from providing high quality supportive care, which is where we really should be focusing our efforts on. Everything we do to a patient means that there's something else that we might not be doing at the same time as well. So really thinking about this as well in terms of distractions. So clearly there is tremendous potential for harm. And as we go forward with COVID-19, we should keep that in mind. Next slide, please. So what should clinicians do? Let's talk about this concept of sensible medicine. Next slide. This is actually a framework that I find quite compelling. It was published by Christopher Seymour from University of Pittsburgh and with collaborators from other universities, including some Europeans from Oxford. And really the idea of trying to find a balance between being a medical nihilist, which says nothing works, there's nothing for us to do, versus these hawks who are trying everything that's new and under the sun with the argument there's nothing to lose. And what we need to do is really combine that skepticism of new evidence with an accelerated pace of knowledge translation and find a sweet spot where we actually are able to practice sensible medicine. And it's a lot easier to talk about sensible medicine in November than it was perhaps in March, because we do have now a body of literature and we do have a lot of lessons learned. But I do believe that it's still important as we move forward to keep this in mind, because it's a reminder of how to really practice the best available evidence for our patients, or evidence-based medicine for that individual patient, even in the context of a pandemic. Next slide, please. So there's 5 strategies that we can apply to practice sensible medicine and to kind of root us ourselves back and recognizing those heuristic and cognitive biases as we think about potential therapies for our patients. The first one is medicine without magic. So on the left, you have actually a very complicated paper published in Science where they did a biological assessment of immunity to mild versus severe COVID-19. And what they found is that the number of pathways involved and the number of cell lines and enzymes that are activated is very complex. These are complex immune responses, which are far different from the basic kind of chronograms or diagrams that people drew to justify, for example, the use of ivermectin or the use of hydroxychloroquine or chloroquine, and really understand that there's no magic bullets for these complex clinical diseases. We can find different ways of treating them and modulating that response, but even in patients who have a very treatable bacteria, if they develop septic shock or ARDS, an antibiotic that kills that bacteria does not solve the whole disease. So the thought that there's going to be a magical cure that all of a sudden takes care of all patients with COVID is really not based on science. So let's not forget that magic bullets in medicine are non-existent. We understand these complex pathways and there's different ways in which we can mitigate these diseases, but to cure everything is very unlikely. Next, please. Practice doing almost nothing. We have to be comfortable with providing supportive care to patients when we don't have good therapies that have demonstrated to work. We do have some now, but at the beginning especially, the unreasoned intervention with experimental treatments may have led to more harm than good. And we are now learning with hydroxychloroquine and IL-6 inhibitors that there's no benefit, most likely, and that potentially we could have caused harm to these patients. And again, if you add these other harms that we talked about, such as distraction and impediment of science, these are things that on the balance have not been positive for our patients. And with the number of patients that we've treated, that obviously is a big problem. So we have to be comfortable with not doing things that could harm patients and that we don't have proof that actually work. Next, please. We have to elevate usual care. I have seen in some of our ICUs that as people were trying all sorts of therapies, they were not maybe executing things or interventions that we know work very well based on multiple trials, such as the ARDS net for patients with ARDS, or the A to F bundles and patients who were in the ICU. So really giving our usual proven care or supportive care the best chance to work, and really focusing on delivering that at a high level is another way or another strategy to really enhance our practice of sensible medicine. Next, please. Focusing on high quality evidence is extremely important. So we have the traditional pyramid of evidence-based medicine that starts with case series and reports and goes all the way to systematic reviews or meta-analysis and randomized clinical trials. But what we know today is that this is not a straight pyramid, but it's kind of wavy in terms that it's not only the type of design of a study, but also within different studies, it's the quality of each study that really matters. So there are some randomized trials that might have less value or less weight than very large and well-designed cohort studies. And as we continue to see more and more publications related to COVID-19, it's the conglomerate of all those publications that ultimately inform the available evidence. Another important aspect is I think that the preprint services have value for the scientific community, but in the midst of a pandemic, when people are taking preprint, pre-peer reviewed studies and using them as evidence, that can be dangerous. We saw a number of these studies eventually be retracted or not make it through peer review. And ultimately, what we also saw is that a lot of credence was given to very low volume, very low volume and low quality studies. And as we move into higher levels of evidence, all those that were initially positive in case control studies or cohort studies, small cohort studies, are now negative in randomized trials. So focusing on high quality evidence is important. The peer review process is not perfect, but it's what we have. And I do believe that if following the aggregate of data published and higher level evidence is very important. To that effect, when you look at steroids, we've had large randomized trials, subsequent randomized trials, and we have a meta-analysis. So that gives us more confidence that that probably is more likely to be beneficial for our patients than harmful in the right situation. Next. And the last one is to think in a Bayesian, using Bayes' theorem as we apply this. And Bayes' theorem, this is actually the formula, but really what it gives you is it gives you a probability of a given result, either in a test or a therapy, based on previous results and based on prevalence. So when you apply this from a diagnostic standpoint, if you are in a situation where the incidence of COVID in your community is very, very low, a positive test is more possibly a false positive, and negative is more likely a true negative. If you are in a situation where you have a large incidence of COVID in your community, it's the contrary. A positive test is much more likely to be a true positive, and a negative test is much more likely to be a false negative. So when you think of diagnostic tests, and Nate had spoken about this many webinars ago, it's not only how sensitive or how specific a specific COVID test is, you also have to understand what the pretest probability based on the incidence is, and that really determines a lot of how you think it. But it also applies to treatments. And a great example of this is IL-6. IL-6, most of or hydroxychloroquine, most of these have been tried in other similar diseases, or other viruses, or other situations such as ARDS, and they didn't work. So very low pretest probability of reworking. And then you look at the available evidence that's for and against, and what we find is that the only evidence for are very small and poorly designed studies, and the evidence against now is growing and is based on randomized studies. So if you were to plug all that into a Bayes' theorem equation, the probability of any of these therapies really working of these specific therapies is extremely low. So apply this way of thinking to diagnostics, but also as therapies emerge, I believe it's a very important tool. And there are some studies now. There's one of the corticosteroid studies that actually now reporting the results in the Bayesian model, which gives you a probability that it's that actually it would be positive. So for steroids, they did that, and it gives you a probability that it actually improves outcomes of 90+%. Next, please. And the final portion of my clinical update relates to remdesivir. And the reason for this is that a couple of weeks ago, remdesivir was FDA approved for COVID-19. It's the first drug that is FDA approved. That is a distinction from a emergency use authorization that other drugs have received, and Nate will share with you one that has received it recently. So this is the first FDA approved drug. Velcluri is the commercial name, and FDA said is indicated for adults and pediatric patients 12 years of age and older, weighing at least 40 kilograms for the treatment of COVID-19 requiring hospitalization. So it's really thought to be a drug that is mainly given to patients who are hospitalized. There's a lot of controversy, as you'll see, but let me just show you very quickly what this is based on. Next slide. There's one randomized trial that was published earlier this year that came from China. It was a study that was stopped early due to lack of enrollment. And what they looked at was a randomized trial of 10 days of remdesivir versus placebo. The primary endpoint was time to clinical improvement by day 28. This was a negative study. This was published in March, and it was not part of the decision-making of the FDA or the CDC when they first gave the emergency use authorization. So there's 3 studies that the FDA cites in their approval. Next slide. The most important one is the NIH study, the ACTS trial, that was initially published in preliminary form, and that led to the first emergency use authorization. And this is actually the final report of that study, where they enrolled a little bit over 1,000 patients. And what they found is that the use of remdesivir over placebo improved time to recovery from 15 to 10 days on the final. But there was no improvement in mortality or in other of the secondary outcomes. But there was an improvement in a time to recovery of symptoms. So that is perhaps the most important study, and based on this, they moved forward with the FDA approval. Next slide, please. This is one study that was published that showed that there was no difference between using 5 days and 10 days, but this study did not compare to placebo, so it just compared to 5 versus 10 days and found no significant difference, and that's why most hospitalized patients are by the FDA are getting 5 days of remdesivir. And then the final study, which is also a Gilead or drug-sponsored trial, next slide please, is a similar study where they compared the effects of 5 days, 10 days on 11-day status of the patients. And what's very interesting about this study is that they showed that in the 5-day group, at day 11, there was better improvement or significant improvement compared to standard 10-day, but they didn't see that significant difference at 14 days. And in the 10-day group that on average got 6 days of therapy, they didn't see that impact either. So this is a study that is confusing. It does suggest one of the endpoints was positive, which is the 5-day course on and recovery at 11 days. But again, when you look at these 3 studies that are referenced by the FDA, it doesn't seem that remdesivir has a clear benefit other than maybe improving days of recovery in some hospitalized patients, and there's clearly no impact on mortality as shown by these studies. Next slide. Despite this and the fanfare of the FDA approval, which has created a lot of controversy because some think that there was a lot of political push for that. Recently, also, the WHO announced that both remdesivir and interferon fell flat with no impact on mortality in their very large multinational study. The manufacturer of remdesivir has pushed back against this study, which has not been published yet in peer review form, saying that it involved multiple countries around the world and that perhaps the quality of the study is not up to sniff. But the reality is that there are other studies with remdesivir coming out, and we'll have to see. As of now, the data to support its use is not impressive, but I think that if there's an FDA-approved drug for COVID right now, it would be difficult for us not to offer it to our patients at this moment. And what we probably need to understand that is based on what we have available, what it probably does at best is improve time to recovery. So with that in understanding, I think as of now, it probably will be part of what we'll be doing. And with that, I'll send it back to final. This is just from the NIH guidelines, and that's the link. And you can see that really they're recommending now the use of remdesivir and dexamethasone for patients who are hospitalized and requiring oxygen. Remdesivir is preferred early on for those who are not intubated if possible, but are in the hospital on oxygen. And dexamethasone clearly indicated, especially for those who are on the ventilator, but also for those who require oxygen or high flow oxygen or BiPAP. So these are the two drugs that right now are being pushed by the NIH guidelines, but also probably that have more robust evidence to support their use in hospitalized patients. So now back to Nate.
Thanks, Sergio. Great content. So, you know, as always, one of the things that's really been on the mind of Greg, Sergio, Mark, and really everyone at kind of Sound HQ has been how best to support folks during, you know, what we're seeing now, which is the third surge. And Anand Swaminathan is a fairly well-known emergency physician who's faculty at a residency program in New Jersey, and he's deputy editor of one of my favorite CME products, Emergency Medicine Reviews and Perspectives. And you know, at his facility in Paterson, New Jersey, you know, they had a number of emergency physicians hospitalized, and one who became critically ill, who was in the press during the first wave of COVID in March. And last week, or I guess the week before now, he sent out this tweet, which, you know, I think is worth reading for a moment because it resonated with me, and I'm sure it will resonate with many of you, which is, do I have the resilience to absorb the volume of critically ill patients again? To code and pronounce patients younger than me? What does it say about me as an emergency doc if I can't do it? Even worse, what does it say about me as a human if I can? And, you know, we've really been fortunate, I think, over the last week or so to have, you know, some good news. It sounds like all the effort around therapeutics may be starting to produce some payoff in the form of some vaccines, which seem closer to reality, certainly than they did, you know, 3 or 6 months ago, and some promising new therapies, which we'll talk about in a moment here. The code you see on the slide, which says "Scan me," if you hold your phone or your tablet up to that, it should direct you to the PDF of this article. But what this is a framework that was put together based on Maslow's hierarchy of needs that thinks about how best to support people and protect their mental health when they're caring for patients on the front line. And this is written by emergency medicine physician, Dr. Wong, and some co-authors, but I think is really germane also to hospital medicine, critical care, and really anyone who's involved in frontline care. And there's one thing in this article that I think is worth highlighting, which is a tool that was created by the Veterans Administration. And, you know, one of the things that's really apparent with supporting folks in the front line that, you know, is true in a lot of domains is that not every solution works for every person. And, you know, part of our goal here is to provide a whole armamentarium of tools for folks to see, so they can, you know, try them and see what works for them. And if you scan this code, it'll take you to a link where you can then click on the radio button for either an Android device or an Apple device, and you'll download this kind of coaching software. And you don't even really need to do the coaching part of it, but it has a a list of 12 or 15 totally actionable ways that you can help with your well-being as you're dealing with stressful situations. And if you think you have some PTSD, or if you're faced an issue that's more challenging than just kind of trying to help out with your well-being, there's great tools in there. I would encourage you to take a look at it. It's I think worth a look. Another research or another thing that I'll throw out there is Dr. Rob Orman is an emergency physician and an educator who lives in Bend, Oregon, right near our very own Dr. Rob Zipper. And he has a podcast that explores a lot of some of the interesting literature that's coming out on COVID, but also talks a lot about well-being and has some interviews with folks that are pretty well known in that space, and is another thing that's worth checking out if you're a podcast listener like I am. So with those two resources presented, let's talk a little bit about a couple of studies. So in October, MMWR released early a set of data that looked at healthcare worker infections from the COVID-Net group. And this is, I think 90 some counties in 13 states, and they aggregated about 6,760 cases of COVID. And among those, a significant fraction were identified as healthcare workers, about 5.9%. And it's worth pointing out that this sample is from March the 1st to May 31st. So remember that date range when we talk about the next study that I'm going to highlight. But really what this is remarkable for is that early in the pandemic, there was really not a lot of standardization around PPE use, and making the diagnosis was challenging because there were severe constraints on testing. Testing was totally unavailable, in most parts of the country in the beginning of March. And if it was available, it had a prolonged turnaround time and wasn't super actionable for clinical decision making. So if you look at this cohort of healthcare workers that became ill, you can really see nursing is disproportionately affected. More than a quarter, approaching a third of cases were among nurses. Nurses' aides were another significant, so it's hands-on bedside folks, phlebotomists. It's interesting to me that respiratory therapists were lower on the list, because I think of that as, kind of a high-risk activity. Physicians also affected, but kind of in the mid pack. And if you look at the outcomes in this group, 27% of the healthcare workers, 27.5% actually were admitted to the ICU, 15.8% were vented, and 4.2% died. And, that is a really sobering, set of outcomes for this cohort. The risk factors in this group really the same as, the population at large, all the things you would expect in terms of comorbidities, obesity, diabetes, pre-existing respiratory disease, immunosuppression, active malignancy. So if you contrast that data set with this data set, which is from a JAMA article, lead author Dr. Wang, which was published. This one is actually a couple of months old, but what they did is they looked at the positivity rate amongst healthcare workers in the Brigham Mass General Hospital system. So this is a big hospital system that has community hospitals, but also has kind of quaternary, gigantic academic centers. And, once again, the flow code leads to the study if you want to take a look in detail for yourself. But this chart is kind of the too long, didn't read version, which is that, prior to universal masking, they were on an exponential growth rate of healthcare worker infections. And once universal masking came out, and once they got a handle on PPE, even in the face of rising case numbers through April, they really saw a pretty precipitous decline in healthcare worker infection rates. And I think this just, these two studies, when you compare and contrast them and look at the time period, particularly looking at the case numbers in the green, really highlight the amount of protection that comes from universal masking, great hand hygiene, and just really being meticulous about it. And Sergio's gone through that a number of times in this forum. And I think as everyone is facing pandemic fatigue and, frankly, outright pandemic anger, and facing the third or the however manyth, iteration of a surge in your community, I think it's really important to revisit this and make sure at your shop you have a culture where it's okay to point out gaps in people's practices, whether it's hand washing or mask use or social distancing or whatever that might be. So let's move on and talk about bamlanivimab, which, the naming of these monoclonal antibodies is a little bit of a source of entertainment for me. But the FDA, this is different than what occurred with remdesivir. This is an emergency use authorization, which is kind of a we're going to trust you to show us the data handshake deal that manufacturers make with the FDA. And really, this is based on some data, which we'll go over. Probably the most the most important piece of data is the New England Journal study, which we'll discuss next. But I just want to say a couple words about monoclonal antibodies for COVID-19 and what the role is, kind of how they work. Essentially, what this is you're transplanting in humoral immune response in the form of antibodies to the spike protein. And for that reason, they're not useful late in the course of disease. You don't give these to people that are vented or really sick in the hospital. They are useful very early or even in a prophylactic role after exposure in other conditions. And the study that goes through these, this data is interesting. Basically what they did is they took groups of patients, they gave them 3 different doses of this, LY COV 555 is the other catchy name they have for it. I haven't seen the trade name for this one yet, but people were treated pretty early. They were treated, I think the mean was on day 4 after diagnosis, and there were no deaths in this group. So you got to remember that when you're looking at this data, you'd say, well, why are they looking at viral load as their outcome rather than a clinical outcome? And the reason is because, you're treating a condition where the majority of people, even older people, experience, asymptomatic mild infection or mild infection, and they recover completely. So particularly in a study this size, it's just not powered to look at clinical outcomes. So what they looked at is they looked at viral load on day 7, and you could see the, dispersion of outcomes based on dose. And this cycle threshold basically means how many times did you have to amplify the DNA in the PCR sample to get a result. And really what this showed is that the incidence of hospitalization was lower in those that were treated. But I got to say, there's something in this data that makes me kind of skeptical, which is the asterisk, which interestingly appears nowhere in the text of the article. And I'm not really sure since when presenting to the emergency department gets included in the statistics for hospitalization. And they don't really say, into which one of the groups these patients that presented to the emergency department fell and which ones, were hospitalization. So I think there'll be more data to follow with this. This is certainly a promising avenue of treatment, but there are, I think, some holes in this, in this study. And, we'll know more as larger studies come out. So switching gears a little bit, just we're at time, but 2 more things that I want to talk about quickly, which is, there's been some pretty terrifying stuff about how the SARS-CoV-2 virus can persist for up to a month on paper money. I'm not sure if anybody else saw that, but, kind of concerning in terms of eradicating infection. And this is a study from Clinical Microbiology and Infection, which became available online in September. And basically what they did is they looked at surfaces and potential fomites in hotels where they were cohorting people and also in areas where they were treating large numbers of patients. And they found a ton of SARS-CoV-2 on surfaces, on elevator buttons, all over the place. But the good news is they were totally unable to take those positive samples and infect cells in culture. So, and most epidemiologic experts seem to agree at this point that fomites are not a main mode of transmission. So I think some good news there. Finally, I will close with something that was interesting in BMJ, also in the end of September. And, there's a lot of folks are kind of trying to predict that there's going to be a less severe flu season this year based on the experience of the Southern Hemisphere, which kind of tends to front run what happens in the Northern Hemisphere. There's been really little to no flu, kind of 98% less flu than normal. And, some are saying, well, maybe, I don't need to get a flu shot. And one of the things that's interesting in this English data is that if you're infected with both flu and SARS-CoV-2, your risk of death is about 5.92 times higher. So the rates of co-infection were low. This is a big sample. You can follow the link if you want to read the details, but I think even if there's, some saying it's not going to be a tremendous flu year, it makes good sense to get your vaccine, and that, as I'm sure many of you have already. So that's all I've got. I don't see any questions in the chat. Mark, do you have any closing comments to take us home?
Nate, there are two questions that were in here since the very beginning, and I think they have relatively quick answers. Let me just see if Sergio, can you just comment on hospitalized patients getting remdesivir, and if they're improving, do they need to stay in the hospital to get the full course, or can they be discharged?
That is that's an excellent question. And the way that if they're improving that quickly, so that the therapy is 5 days. If they're improving that quickly, I would imagine they have very mild disease. What the FDA says is that they should be receiving remdesivir in some sort of healthcare environment. So you could either stop it probably if in case they probably didn't need it, or arrange for them to get it in some sort of environment. But I don't think these patients are taking the remdesivir home with them.
Okay. And then, Greg, maybe you have some insight into this. Is there any information about what the vaccines might cost the public in general to receive it?
We don't know any detail right now, other than Pfizer had specifically stated that they intend to offer, assuming that the vaccine is safe and available for distribution, and they have asked for, they have stated that assuming everything else tests positive or tests okay, that they will ask for an emergency use authorization. But Pfizer specifically stated that they would make it free.
Okay, fantastic. Thank you, guys. That was a fantastic presentation. And one of the things that I thought was amazing is it's incredible how much has been learned. And yet, Nate, towards the end, you presented the slide about the impact of masking. And the thing that we've known about probably since earliest on in this whole process about masks that can prevent the illness is perhaps one of the things we've struggled with the most. Nevertheless, we'll hope for the future that we can all abide by that simple intervention. Any closing comments, guys?
As always, thank you for what you're doing. And, this is created by us for you. So if you have something that's on your mind that we can talk about, send it our way.
Fantastic. Thanks, everybody, for joining us. We'll send out a link if you like the presentation. Encourage your colleagues to take a listen and a watch, and we'll see you next time.